Good afternoon, everyone, and welcome to the officials of the Ministry of Health and other health agencies, members of the media, and members of the listening and viewing public. My name is Bridget Anisette George. I'm the chairman of the Public Accounts and Administration Committee of the Public Administration and Appropriations Committee of the Parliament. The Committee of Public Administration and Appropriations has a mandate to consider and report to the House on A, the budgetary expenditure of government agencies to ensure that expenditure is embarked upon in accordance with parliamentary approval. B, the budgetary expenditure of government agencies as it occurs and keeps Parliament informed of how the budget allocation is being implemented. And C, the administration of government agencies to determine hindrances to their efficiency and to make recommendations to the government for improvement of public administration. The purpose of this 23rd public meeting of the Public Administration and Appropriations Committee for the 11th Parliament is to commence an inquiry into the administration of special health care programs in Trinidad and Tobago. The committee is desirous of hearing from the Ministry of Health to discover any challenges being faced by the ministry regarding the administration of special health care programs in Trinidad and Tobago. The committee hopes that the meeting will be fruitful, that it will provide insight and workable solutions for the improvement of the administration of special health care programs in Trinidad and Tobago. This meeting is being held in public and is being broadcast live on the Parliament's Channel 11, Radio 105.5 FM, and the Parliament's YouTube channel, ParlView. Viewers and listeners can send their comments related to today's inquiry via email parl101@ttparliament.org, facebook.com/ttparliament, and Twitter @ttparliament. I therefore now invite the representatives of the Ministry of Health and the other health agencies to introduce themselves to the committee.
Good afternoon, Madam Chair and members of the committee. I'm Richard Madre, Permanent Secretary.
Good afternoon, Madam Chair and members of the committee. My name is Vishwanath Ande Pratap Singh, Acting Chief Medical Officer.
Good afternoon, Madam Chair and other members. I'm Rohit Joon, Public Health Advisor, Ministry of Health.
Good afternoon, Madam Chair and members. Lawrence Jai Singh, Director of Health Policy, Research and Planning, Ministry of Health.
Good afternoon, Madam Chair and members. Bisham Sitaram, Program Administrator, Ministry of Health.
Good afternoon, Madam Chair and members. My name is Dr. Jeffrey Edwards. I'm the Director of the Medical Research Foundation.
Good afternoon, Madam Chair and members. I am Kevin Antoine, Program Director for the HIV and AIDS Coordinating Unit.
Thank you, gentlemen. And may I now invite the members of the committee to introduce themselves, starting from my extreme right.
Hi, afternoon, everyone. Jennifer Rafu, member.
Good afternoon, everyone. Wade Mark, member.
Afternoon, Lakram Bodo, Vice Chairman.
Good afternoon, Nicole Olivier, member.
Good afternoon, Brigadier Ansel Antoine, member.
And the committee today is being ably assisted by its secretary, Ms. Kiba Jacob, and its graduate research assistant, Ms. Rachel Nunes. I would just like to start off the discussion with a general inquiry to the Permanent Secretary of the Ministry of Health. In that, as I indicated, the discussion was about the administration of the special healthcare programs in Trinidad and Tobago. And we've observed from the responses to our inquiry that the responses were limited to Trinidad. And therefore, for our clarification, if maybe you can begin in making an opening statement, but also weaving into the context, where does Tobago fit into all of this?
Madam Chair, committee members, the 4 PSIP programs relate to the work of the ministry in respect of our programs to assist Trinidad. The Tobago House of Assembly is responsible for the management of its funds regarding the treatment of Tobagonians generally. However, from a policy perspective, the Ministry of Health sets policy initiatives for the nation.
Okay, so that will include Tobago?
Correct.
Okay. So that, but therefore, in terms of the responses to the questions with respect to how the programs are administered, there was no reference to Tobago at all. So, so that how then, in terms of you setting policy, there's an absence of any reference to Tobago?
Well, I believe that we attempted to address the fact that the inquiry related to the public sector investment program allocation of the ministry, so we focused our response in that way.
Okay, thank you very much. All right, so that I will now pass on to Member Budo to begin the conversation as regards the specifics of the inquiry. Member Budo.
Thank you, Madam Chair. Good afternoon and welcome. I see many familiar faces here, and special welcome to you all. I just want to start the discussion, and if I could refer to page 1 of your response, PS, and just for the clarification, the public's eye regarding the special healthcare programs, I see we have listed under item 2, identify the special healthcare programs within the ministry. The external patient program, can we get clarification? Does that just include the 3 listed under the external patient program?
Mr. Sitaram will clarify.
Under the external patient program, we manage specifically these 3 items. However, medical aid and the eyeglasses project, as well as the external radiation treatment, is administratively managed under the program.
All right, so in terms of listing, they would come under the external patient
administratively program. Correct.
Right. I just wanted clarification, so we could deal with all of these as a block. So PS Trio, if I can perhaps engage the director of the EPP, and just to ask, in terms of how much has been spent on the EPP so far in this financial year, can you give us an indication?
Under each line item, we'd have different expenditures.
I just wanted a ballpark figure so that we will have an idea what sort of expenditure we are dealing with.
Can you use this, or you have it?
For adult cardiac, we would have spent 5.05 million. For renal dialysis, 12.9 million. For waiting list, we would have actually spent 5.7 million. The other line items, I would have to get the figures for.
Yeah, that's fine. Director, can you tell us approximately how many patients would have benefited from this expenditure under this program?
Under every line item, we have varying numbers. For example, adult cardiac, it depends on the number of persons that present at the hospital. Renal dialysis, currently we have 1,187 patients that are receiving treatment. The waiting list initiative is really based upon the number of persons that are awaiting services at the public institutions as well. So that will be time-based. The medical aid is based on the number of persons who apply and are presenting to the public healthcare system. The eyeglasses project, we would have provided a detail for fiscal 2018. We have 300 applications that are being processed currently. One of the things I would like to put on record is that all of these programs are available to members of the public who present at public healthcare institutions.
Sure. All right. So, but in terms of a ballpark figure of the total number that would have benefited under this expenditure?
Under this expenditure,
we would, to give us that?
A ballpark figure would be safely roughly 7,000 persons.
7,000?
Yeah.
Okay. So if I may, there are some more specific questions I want to ask regarding the programs themselves. But before I go into that, there are a few general questions I would want to ask regarding the external patient program. Do you believe that the EPP has been able to achieve its target and objectives? Do you think the program has been a success?
Thus far, yes. We have been able to meet the needs of the public. There have been some challenges in the past, and we continue to face challenges. However, we are able to meet all of the requirements of the public thus far.
Right. Can you perhaps maybe list some of these challenges that you mentioned?
One of the major challenges that we face is basically patients presenting directly to the ministry and not going through our public healthcare system. That's why I wanted to state from the onset that patients must belong to the public healthcare system. The challenge we have is that there's a culture that needs to be changed, whereas patients feel as if they can go to a private doctor and then depend on the government to pay for any service that they require thereafter. The program, all of our programs are geared towards patients who are within the public healthcare system and patients who are being treated there. So the major challenge is getting patients to actually access the public healthcare system.
Right, and that may be so, but in terms of someone seeking care at a private institution, in an emergency situation and want to access the EPP, let's say, for example, with an acute cardiac situation, are you saying then that the patient has to go into the hospital system to be able to access the service?
Once a person presents at any one of our accident and emergency centers throughout Trinidad and even Tobago, they are immediately, the system kicks in that we get the request from the hospital and the person is transferred to a private center to have the emergency surgery done once to present our accident and emergency.
So the public needs to understand that.
Yes.
Yeah. Do you have any ideas, any suggestions as to how the program can be improved going forward?
In terms of going forward, possibly public awareness, education, and in essence, funding has always been a challenge throughout successive years, but it is not, these programs are not meant to last forever. These programs are meant to fill a gap and meet the needs of the public at this point in time while we build institutional capacity. So in that interim, funding would be one of the things that would benefit us right now.
Yeah. Do you have in place any mechanism currently that can measure the impact of the EPP in terms of the provision of service?
One of the things we look at in terms of measuring impact is really the number of complaints. From 2014 going forward, the number of complaints of persons not being able to access any sort of service, we have been able to bring that number significantly down. So whereas in the past we would have had hundreds of complaints of persons not being able to access basic services such as CTs and MRIs, that no longer obtains. Once a person is made aware that this facility is available, they access the facility, and therefore the complaints, we have seen a significant decrease.
Is this program advertised publicly? How is the public made aware of this?
All of our CMOH offices have offices located there in which patients can go in and apply. All of our accidents and emergencies at public healthcare systems, institutions, are aware of the program.
Right,
so patients, once they go in, they can get the information there.
So if I am to understand correctly, you have two situations. You'd have acute situations where someone would present an accident and emergency, but you also have the waiting list initiative. Can you specify what that waiting list initiative is about and what services it covers?
So the waiting list initiative basically directly speaks to persons having to wait for an extended period of time to have any service. So we look at periods for about 3 to 6 months. So a person should not be waiting for a CT or an MRI or even for cataract surgery for more than that period. We try to absorb as many of them within the public sector, and those that we cannot get done within that period of time, we then try and get them done privately.
So just to be clear, so the services are CT, MRI, and
CT,
cataract.
MRIs, cataracts, yes.
Any other services?
Well, I think
those are the main areas of focus.
Those are the main areas of focus, correct.
All right. So you're saying to the public that if they have an appointment, for example, for an MRI at a public institution, that's longer than how long should they then try to access the program?
Once they are waiting for more than 3 months, they can approach any one of our county medical officers of health office and apply, or come directly to the Ministry of Health. We have an officer located waiting and able to assist, to provide any sort of guidance needed in order to tell them what needs to be done, one, and what are the requirements. Because you don't just say you have to go in privately. There must be some sort of proof and evidence that you have been waiting, and these services are available to all citizens of Trinidad and Tobago.
I understand that you will not want to open the floodgates, but for those services, is any effort made to communicate to the public, besides the notices at the CMOH's office, which, generally patients may not visit on a regular basis? Have there been any efforts to communicate that this assistance is available? I'm speaking specifically in terms of advertising the program outside of the CMOH offices.
Currently, it is on our website and on our Facebook page, so the information is out in the public domain.
Do you believe it might be of benefit perhaps to advertise otherwise? Has any consideration been given to that?
It is something that we can consider moving forward, yes.
Just, thank you. Mr. Sitaram, just for me to understand, so that a patient could be in the public health care system. A doctor there says you need to get a CT scan or MRI. And you get an appointment for that to be done in the public health system for a year from today. That same patient can now go to a different office in the public health system and say that my appointment is a year down the line. And therefore now I want to be on the waiting list initiative. Is that how it works?
No, it's not.
Okay.
If a person has an appointment date, you must present it on that date. If on that particular day the service is not rendered, then you start waiting. We ask persons who have been given extended appointment times or dates to actually write to us or call us. We try our best to bring up dates. So whereas, yes, the facility is available to send persons privately to have procedures done, whether it be CT, MRI, cataracts, we try to manage the system in such a way that we get the procedures done within our public sector.
So that after, I don't want to call it the waiting time. So after the expiration of the time between my being referred for the particular service and the appointed date, it's only then I qualify for the waiting list initiative.
Correct.
Okay, because I think the public needs to understand that. And when I then now qualify, then I apply to be put on the waiting list.
Yes, correct.
Okay. How then does that impact? Because I would think if my waiting my appointed time was a year down the road, so we're now in May of 2019, and I presented myself in May of 2019, and I didn't have the procedure done. Would I automatically be assigned a different time?
If you present at a public hospital and your appointment is today and you don't have the procedure done today, you're automatically given another appointment. At that point in time, you can apply to us. However, you are given an appointment.
So I can apply to bring forward my appointment?
Correct. Yes.
Could you share with us what are the criteria to determine whether my appointment would be brought forward?
I beg your pardon, sorry.
Could you share with us what would be the criteria to determine whether my appointment would be brought forward? Because I don't automatically get an earlier appointment than the appointed date.
So if it is you're giving an appointment for 1 year, and on that date, the procedure does not happen, you write to us, you tell us exactly what the situation is, we then try to assist. Once there is a facility available within the public sector, we utilize the facility. There are several reasons why it is some RHAs may be more efficient than others, and we utilize the system in such a way that we move patients from one area to another in order to get procedures done. So, for example, we would do waiting list runs. We did a waiting list done at Mount Hope a couple of months ago to have procedures done. That will deplete the list that currently exists right now.
All right, so that what you're saying is that I may have got a deferred appointment at a particular facility, but through the initiative, I may get an earlier date at another facility. Yes? Can I ask why that couldn't be automatically done when my appointed schedule could not be met? Because from the way I'm understanding, it's not through any fault of my own, the patient. This is maybe something with the facility. Why couldn't it be automatically be done at the time I'm getting the deferred appointment?
So there are several reasons why appointments are deferred. It could be that the machines may malfunction. There may be staff shortages. There may be several reasons. Those are basically some of the reasons why the appointments are not kept.
And what I'm asking is, why at the time that my appointment cannot be kept for a matter that is outside of my control as a patient, why couldn't it automatically kick in? We have technologies all being managed by one overarching entity. Why couldn't it then look in terms of setting a date for me for the next available date throughout the system?
It does not kick in automatically because we have different RHAs and each operate independently of the other. What we're trying to do is to mesh the system in terms of service delivery. That is what we try to do by moving patients from one RHA to another and utilizing the services available by the other RHA.
But maybe I don't understand, and maybe I'd give you an opportunity to clarify. I just said that they were operating independently of each other, okay? But yet it's being meshed by somebody, which I think is what the Ministry of Health.
Yes.
So what I'm asking is, I see that as something that can be done electronically. Am I wrong? And if it can be done electronically, why is it not being done?
Each of the RHAs operate with different systems in terms of record keeping. So the joining of the systems is something that's being looked at. But from an administrative point of view, it's easier for us at this point in time for us to do the transfer or to help the patient get the service done at another institution. Until all the systems can correlate and speak to each other electronically, that cannot happen.
Can't all the systems speak to you?
If I may, so what we have found is that and I'm just endorsing what Mr. Sitaram said, what we have found, precisely because the RHAs were set up separately, over time they've diverged in many different ways, right? And this is just one way in which it's an obvious example. So to a certain extent, the Ministry of Health needs to find ways in which we can find ways in which we can better coordinate and integrate those RHAs, despite the fact that the legislation was set up for the RHAs to be separate. So we take the point. I mean, it's an obvious point that you're making. We take the point with respect to the need to find a way for such integration. The IT technologies is, in fact, one way. Of course, what we're doing through the EPP program and Mr. Sitaram's office is, in a way, a workaround. For the time being.
Yeah,
we're trying to achieve the integration or the service delivery,
yes,
but without the technologies that support it.
And therefore, I would ask then, when do you, from what you know as the Permanent Secretary, see the assistance of the technology coming to aid this system?
We do have, all right, so this will be a program of projects over a series of time. Introducing IT technology systems is always challenging, whether it's here or anywhere else in the world. And we can see what happened in the United States when they tried to implement their national health insurance scheme. Their system went down for a period of time, even though they had access to all of the best resources. So it will be a challenge. We are doing two things. We are beefing up. We have advertised for positions in our ICT division, and recently Cabinet had approved additional positions for that unit. That will provide a central coordinating function once we get the kinds of expertise that we need. One of the projects that is on our agenda is a PAC system. I forget what the acronym stands for, but basically it is a system to ensure that the that the screenings, the diagnostic imaging, and investigations can be shared from one hospital to another. If we can get that system in, it will be one phase of our program of projects over a period of time. I can't give you a timeline for that project as yet, but we are working on defining that project and finding a way to make it happen. Okay. But without the bodies in the ICT division to manage it, I think that is our first step. We are estimating from those who have been somewhat engaged in the project about a 1 year to 18 months for the PAC system. Yeah, and as I said, a prerequisite for that is in fact getting the human resources in place.
I know, but you said that that's just one phase to where we want to get, with the systems being, not necessarily the RHAs, but being integrated with the Ministry of Health. Because right now the Ministry of Health is doing something manually. I must come in and make a complaint and so on. What I'm really saying is, if you're doing it manually, right, so we're not even talking about the RHAs being able to speak to each other, so to speak. But since you are providing that sort of overarching coordinating function, I'm asking, one, whether technology, if there were, that you could speak to everybody, if that would not improve the process. Because I would feel that any patient who went to an institution having waited a year for their appointment, because I'm sure I would be considering that my waiting. And for whatever reason, good, bad or indifferent, my procedure could not have been performed. It must have some kind of psychological impact on me. And then I'm now being told I have to go somewhere and fill out a form and wait for somebody to assess my form for me to go to some other place maybe when. So you know, that alone may kill my spirit if I had any after a year. So one, I think the technology, if you could speak to everybody, meaning that you could see what everybody has available real time, that I could be, as a patient, sent automatically, rather than tell me I have to go somewhere else and pick up a form and fill it out and then go. And that is what I'm asking. How long do you feel you could bring that initiative? Because I understand what you're going to tell me about the technology and the systems, and they might marry and all of that. I'm not technologically minded, so I don't mean any disrespect, but I understand that there are problems. How soon you think a project like that, one, whether you think a project like that makes sense, and secondly, how soon you think that something like that could realistically take place? So I don't have to go somewhere else and get a form and then come to you.
Let me say that anything that I can say here would be a guess, because the planning for this and the assessment of it has not been undertaken. But my estimate would be a normal cycle time for an IT project, all things being considered, may be somewhere around 4 years or so. 4 years. But I also want to add that, in fact, there are some elements of IT solutions that are already in place for some services. And perhaps Dr. Antoine or MRFTT may wish to speak about the solutions that are in place for the HIV management.
Okay, so we'll take that under HIV. I just don't want to dominate the conversation. I just wanted to ask Mr. Sitaram one other thing. When Dr. Bodosa asked you about achieving the objectives, and so what you said is that the system was working because you all are meeting the requirements of the public. Maybe I could ask you to share with us what that means.
So in terms of meeting the requirements of the public, we have been able to meet all of the requirements of the public with respect to cancer care. We have no patients complaining of not being able to access external radiation. With respect to our cataract initiative, both within the public sector and the private sector, we have been able to meet the demand with our CTs and MRIs when patients go to any one of our public institutions and they cannot get it done at accident and emergency, the request is electronically sent to us and it's dealt with, and the person gets the CTO MRI done within a matter of a day or two so that it can be diagnosed and treated. So we have had many success stories. Unfortunately, the success stories are drowned by the few negatives.
Okay, so maybe that goes back to what you said about public awareness and education. Member Raful.
Thank you, Chair. Thank you all for your work for Trinidad and Tobago and for the information you all submitted. I had a few questions mainly about the objectives and the metrics for impact. Going through the submission, I hadn't seen a lot of information on how the impact analysis is done. As an economist, I know that in the past, in general, worldwide, not just in Trinidad and Tobago, a lot of programs had very qualitative objectives. So things like serving the population, as opposed to looking at numbers like specific numbers and specifying a time frame, etc. I'm wondering if you guys think that the metrics you all have and the objectives are adequate or if they need revision. That's one question. Before I forget, there's a few others that I had. I didn't see any financial references at all. I saw one note about the cost of the renal dialysis in the public sector provision compared to the open market rate for private sector compared to what you guys were able to negotiate. But from the 8 programs listed, that was the only reference I saw to financial projections and costs. And I didn't see any costs for administration versus patient care. So my questions really are about objectives and metrics.
Pierce, I think that's a question for you.
Well, I'm trying to divert it to Mr. Sitaram. So let's see whether between us we can really respond.
In terms of the metrics, as I stated before, each of the programs speaks to a different category of patients. So, for example, external radiation treatment, our number of patients that come to us, all 100% are treated. So there's absolutely no waiting time. For cataract surgeries, we try to keep the waiting times well below 3 months. And in instances where it is beyond that, we make special attempts to bring that time period down. It is something we can look at from an economic perspective, how it has impacted our public sector and private sector, as well as our expenditures. With respect to our expenditures, we actually do have very competitive cost for all of our programs. You're correct in terms of our reference to renal dialysis, but the same applies for all of our programs. Our costings are well below market value because we have negotiated the value down. So that even though you're getting the same service, probably better administered because we have several checks and balances to ensure quality service at a lower cost to us. If you were to present as a private patient, the cost would be probably 2 to 3 times more.
Okay.
So what has happened, for example, with respect to renal dialysis is that because the barriers for entry into the market are so low, people can set up services fairly easily as opposed to cardiac treatment. We've had a number of players entering the market, and therefore that brings about competition. So the services are not just provided within the public health sector, it's also provided by the 17, I believe, 17 current service providers that we have. And therefore, through tendering processes, we are able to manage the costs there, as one example.
Okay. As a follow-up question, can you provide the financial data, audited financial statements, and specifically numbers of persons that have received treatment? I do know that the information provided had some numbers, but I did notice there were some discrepancies in the numbers for HIV and AIDS patients. One table had 80-something thousand patients listed, And then a few pages later, there was a reference to 8,900 patients and then 7,000 something patients. So I was curious as to if that 80-something thousand was a typo. Can you provide financial data going forward and accurate numbers?
Yeah, Dr. Antoine will respond. I think I'm hearing that it is a typo. The 87,000 is a typo, but perhaps you can provide clarification, Dr. Antoine.
$8,476.
Okay, thank you. I had a few other questions. Let me check the notes that I had made. Forgive me. If anyone else wants to
maybe
ask
yes, maybe
ahead,
I will
come back with my
ask Member Olivier, and then we go to Dr. Booth.
Thank you very much. If you can go back to the waiting list initiative, in your earlier response, you indicated that that you'd periodically do a waiting list run. Could you just elaborate on what that entails?
So in essence, what we do is that we engage doctors to do special runs. Late last year, we engaged doctors to do an orthopedic run at Eric Williams Medical Sciences Complex, and we were able to achieve well over 50 patients over a weekend. So by engaging special runs such as these, and the ministry has undertaken to do a cataract initiative, we have done it in Port of Spain, we are doing it in San Fernando. These are special runs that we do on weekends, and it's the same doctors that work in the public sector, and it brings the waiting time down.
Well, naturally, my follow-up question would be, is this something that can be done, say, more frequently then, so that you could eliminate the large backlog that would go into a waiting list?
Coming out of the success of the recent runs, it is something that we're definitely looking at.
And if you can clarify, so the waiting list initiative, it only entails CT scans, MRI, and cataracts, or other facilities provided through that waiting list initiative?
Those are the major facilities that we provide, because all the other services, we tend to get it done at the public institutions.
Within a
reasonable time frame, yes, correct.
And we found that those particular services are likely to have the greatest impact on the citizens.
Okay. Now, one of the major concerns of persons assessed in the public healthcare system naturally is the waiting list, having to wait that extensive period of time. And taken from the example that the chairman would have drawn on earlier, where you would go in and you get an appointment for a procedure, and the appointment date is a year hence. Should the person really have to wait 1 year before they can access an accelerated period, or could you simply have a standard of response time that no one should wait more than perhaps 3 or 4 months for a procedure? And then that would trigger then the need to do a specialized run for that particular procedure. So it's really a form of managing the provision of particular services throughout. So perhaps if there is some automatic way of knowing that once appointment dates start being made for in excess of 3 or 6 months into the future, you start capturing that data to see what you can do to accelerate the provision of that service, because that would mean that the service is being requested at a more frequent rate than the facility is able to provide efficiently.
Madam Chair, through you, thank you very much. And your point is noted. I think that is exactly what happens in the system when a patient or someone, a client, interacts with a healthcare provider and a service is requested. That is the standard by which such a date is given. It's referenced based on a range of factors: their age, primarily the nature of the complaint, the nature of the investigation, and the value of the investigation to the treatment or the management plan. And that is the target. The target is to try to have that done in the time frame that would make best sense for the management of the patient. Given that context, and now we recognize, superimpose that on the context that we have a situation where NCDs, the burden of NCDs has increased. The number of cases of NCDs have increased. The number of requirements for tests, the number of persons, that has increased, and has increased dramatically. over the last years. We've undergone, our population is also changing. We've undergone that stage 4 where we contracted. So the population being contracted, lower range of the pyramid, we have more persons who are living longer lives, and with that, increased number of NCDs. So it's really a combination of factors that has allowed the system to now come to a point where, well, coming to a point where its burden is overburdened with the number of requests. But plans are in place, and over the years, we have managed to increase the supply of those tests. We've managed to do so by the increase of some equipment, by services. There are other programs. It is a work in progress. It is a system that is a reality that is not only limited to our context, is limited across the world, and especially those countries having undergone that transition where you've moved away from the infectious disease to the NCDs. It is a reality of the system, but the standards we do try to maintain those standards. I don't know if that, perhaps that would answer your question. I mean, from the healthcare provider's perspective, I do know that it is an argument, a discussion that goes on within themselves. You know, what is the best time frame I can give this patient, and at the same time manage the resources that we have. At the same time, we know that we put in for increased resources.
Okay, Dr. Bodo.
Thank you, Madam Chair. I wanted to address cardiac disease, but before I go there, PS, is just a thought I want to throw out. And there's a concept of machines that sleep from 4 p.m. in the evening to 8 a.m. the next morning. I know that the current working hours for ultrasound, CT, MRIs, and so on, the standard working hours would be 8 to 4. I know in some cases it might be extended. Has any consideration been given to utilizing these machines, perhaps adding a shift, say from 4 p.m. to 12 midnight, to utilize these machines and use that as a mechanism to decrease the waiting lists? And perhaps you could compare the cost of doing that initiative as opposed to what you would be paying a private provider. Is that something that has been considered? And not only on the weekdays, and on Saturdays and Sundays as well, similar to the waiting list initiative you do on a Sunday.
Yeah, so you're right. I do know that some of these runs are being done over the weekend. I'm not sure whether it is also being done on a shift basis, but it is a good point, and we will take it under consideration.
Yeah, I know you don't have control over the RHAs directly, but perhaps it's something that could come up in discussion when you will meet.
Yes.
But
thank you for the point.
Thank you. If I could go back to page 8 and look at the adult cardiac program, and Bishop, you mentioned that about $5 million was spent to date this year, and I see 792 patients listed. And maybe I could engage Dr. Partap Singh as well, just to give us an overview of the burden of cardiac disease, because I know it's one of the issues in Trinidad and Tobago that faces the population. Would you be in a position maybe to tell us in terms of numbers what the figures would be for cardiac disease?
So I can start first with the figures, and then any supplements we can have from Mrs. Hiram. When we looked at cardiovascular disease premature deaths, for example, in 2000, based on 2008 numbers, we see that for males 30 to 60-year-olds and females 30 to 69-year-old, the contribution mortality is 55% of that from ischemic heart disease for the men and 46% for women. Of the cardiovascular diseases, ischemic heart disease is the greatest contributor to premature mortality. Of all causes of mortality as an expression of burden of disease, the cardiovascular diseases account for 30% in the 30 to 69-year-old males and 28% in the 30 to 69-year-old females. Of the NCD group, of the set of causes of mortality in these two age groups and the two sexes, NCDs account for 58% in the males and 69% in the females.
Doctor, if I may, sorry to interrupt you. If we can translate that figure so that the public understands how many men would die per year from cardiac disease and how many women?
So what
the numbers would be?
Out of every 10 men within the age group of 30 to 69-year-old, about 6 of them would have died from an NCD. Of that 6, 3 out of 10 would have died from cardiovascular disease. of that 3, about 1.5 would have died from ischemic heart disease.
So your total numbers annually for Trinidad?
Total numbers for premature deaths for men would have been 2,851, and this is based on 2008 figures. The reason why the figures are quoted there is because the registry data in terms of the death registry. An NCD premature death, 1,656 for men, and for females, 1,723. Total premature deaths and NCDs, 1,197. That's what I have right now for the NCDs. To break that down specifically by number for cardiovascular disease, I don't have that with me at this point in time.
Okay, so you're saying that perhaps maybe 1,000 or 2,000 would die from cardiovascular disease?
So I would say maybe about 800, 900 for NC for men. Let's say about 400 for men, cardiovascular disease, and 250, 260 women.
Right, so we're looking at maybe about 700 people who die from cardiovascular disease per year in Trinidad and Tobago?
We have some 2015, sorry, say that again.
Sorry, you had some up-to-date figures?
Yeah, 2015 figures are in the document. Dr. Doon can report to you more recent 2015 figures.
Yeah.
I'm only asking this because I want to look at the purpose of doing the EPP in terms of cardiac disease. So we need to know what we're addressing. Yeah.
Well, what you've got is cardiac disease in 2015, the latest current data. Heart disease, 2673 persons died.
Right.
And a little more in men than women, marginal.
Of course.
Which would account for 25% of all deaths in the country.
That's fine.
So that's a huge burden. And then from cerebrovascular diseases, which is another subset of cardiovascular disease, just over 1,000, which accounts for about 10%. So in all, 35% of the all deaths recorded in the country would have been attributable to cardiovascular diseases.
Right, so we're looking at about 4,000 persons when you add
heart 26 and 10, 36,
disease and stroke,
3,700.
Okay, so the question I have then to follow up is that in terms of those patients, can you give us an idea of what procedures are outsourced under this adult cardiac program? Perhaps Bisham, you can give us a brief listing.
With respect to procedures, we do from basic angiograms, we do open heart surgeries, we do PCIs, we do mitral valve replacements, we do aortic valve replacements.
What's a PCI? Remember, the public is listening. You need to specify. Stenting.
Stenting, correct. So we do all of the services that are required by the public.
All right. Can you tell me what is the current waiting list for these procedures, roughly?
The waiting list for any emergency procedure is less than a day. For all other patients can vary from 5 days to 2 weeks.
Right. Now, you said the waiting list is less than a day. So somebody comes in on a Saturday morning with an emergency. How is that dealt with in terms of accessing the service?
On a Saturday morning or a Sunday morning, should there be an emergency, the Accident and Emergency Department of Public Healthcare System kicks in. They immediately inform the medical director's office. They send the documents via email to my email address, and we send the patient off making the arrangements with the private providers to have it done either on the same day or the day after.
So you're saying that arrangement is in place
24/7? 24/7, correct.
Emergencies. And the definition of emergency will be that defined by the doctor who's attending.
By the cardiologist, correct.
All right. In terms of the diagnostic procedures like angiograms and so on, which is what you would use to base further treatment, what would be the average waiting time for those
The average wait time for angiograms is between 2 to 3 weeks. If it's an emergency angiogram, it happens within probably 1 to 2 days.
All right. Can you tell us whether any of these diagnostic procedures, like angiograms, for example, are done within the public health system?
Within the public health system, we do the angiograms, and all our procedures are done at Port of Spain General and Eric Williams Medical Sciences Complex. We have, however, engaged private providers to manage our cath labs there. The angiograms, however, we have started to do our angiograms at Eric Williams using skills and the capacity within Eric Williams. In Port of Spain, we are now about to start that process.
So you're saying that there is some sort of transfer of technology?
There is a transfer of technology and skills.
So they are being trained by the providers using the public facilities.
Correct.
Is there any plan to develop this further? For example, to spread to the other areas like San Fernando and so on?
It is something being looked at because, for example, Southwest has gone off a tender for the construction of a cath lab. So the operation of that cath lab will be something that will come out of these training facilities.
All right. Just before I leave cardiac services, we've heard, of the operations of the Cuba Hospital and perhaps in your arrangements that are going to be made. Is this one of the services that the ministry will be looking to purchase from that operator? Are you in a position, perhaps, PS, to answer that?
I can't respond to that question at this time. We will know at some point.
Okay. Therefore, on cardiac, what I would do is to open up the conversation. So remember, all of you, I'll take you back. Senator Mark, I believe you have some questions to ask.
Yes, thank you, Madam Chair. I'd like to put this to the Dr. Pratap Singh, or may I ask whether this number of 3,673 given by Dr. Doon, more or less, would you share with us whether, with a population of 1.4 million citizens, this could be deemed as one of crisis, epidemic proportions, given the size of the population, in terms of cardiovascular diseases? And when we look at international best practice and looking at countries of a similar size, like to Trinidad and Tobago, how would you describe our situation as it relates to this particular number that you have just provided to this committee?
Madam Chair, through you, member, with your permission, Dr. Doon actually is our lead for the NCDs. If you wish, he will be better informed to provide you with an answer, and then afterwards I can always supplement.
Thank you, Senator. It has long been recognized that we are in the midst of an NCD epidemic in this country. And we've been experiencing this transition over a number of years. And we've started working on this particular issue since 2006. And then in 2007, we had a heads of government meeting. So the whole Caribbean, it's a global phenomenon, a Caribbean-wide phenomenon, and Trinidad is no exception. The reasons for it are that, as you well know, is a lifestyle bunch of diseases, and we engage in too much smoking, alcohol abuse, unhealthy diets, and not enough exercise. Those are the four main factors which drive all these NCDs we speak about: cancer, heart disease, diabetes, and hypertension. And they are all comorbidities, it's one influences the other and exacerbates the other. So they are not acting singularly in any one particular person. They are logarithmic in their effect on the human body. So you're correct to describe it as we're in epidemic proportion status. And for that, we have established a NCD prevention and control plan last year. We published a plan, launched a plan, and a number of activities. We've begun to engage in that. And there are four major priority areas first. But basically using a strategy and a philosophy of a whole of government, whole of society approach. So we recognize in the Ministry of Health that we alone can't deal with this issue. It's an issue for all of us. And the philosophy also re-emphasizes the importance of health promotion, health maintenance, and prevention rather than treatment. But what we've been talking about here all along is the downstream effects of what started many years ago. And the epidemic didn't start today. It started many years ago, and it starts in the antenatal period. Dr. Bodo will know much more about that. So that we are addressing concerns in the antenatal period, trying to prevent diabetes from occurring in pregnancy. Because when it starts that early, people tend to get diabetes much earlier in the adolescent years than in the adult years. So we are adopting the life course approach. So at every stage in our development, we are going to be directing, and we are directing attention and resources. One of the major factors in the country today is obesity. And particularly central obesity. I don't mean obesity from shawarmas and so on, but around the abdomen. So central obesity drives this epidemic. And so that's why we have identified that the prevention and control of childhood obesity is really going to make the biggest impact, because the population is already aging, and there you're going to have the bulk of disease. But we want to prevent and break the cycle of this epidemic. And so you have to start at the early childhood stage. And that's where we've been directing a lot of the resources recently. And as you know, recently policy issued by the government to ban sugar in schools, sugar-sweetened beverages, etc. And we've recently completed a BMI survey that is to assess the level of obesity in our school children. The results will be with us within the next week or two. So obesity control at this level is of particular importance, and that's and our plan also, one, encouraging healthy diets in school and making sure the school environment is supportive for healthy diets, and also to increase activity in schools. And also we have some resources to build green gyms in school where they don't have open spaces, and encourage the community to get involved in increasing activity and lowering the frequency of unhealthy diets. So that's in a nutshell the broad scope of approach.
Dr. Doon, could you advise, apart from the initiative taken to ban certain beverages at the school level, kindergarten, primary, even secondary, could you tell us, is there a policy approach on an education-wide basis that has been effected by the Ministry of Health in collaboration with the Ministry of Education to sensitize and to raise awareness and consciousness among the population at the school level, kindergarten, primary school level, secondary school level, so that this crisis could be captured and somewhat controlled in the coming period? What have we done to sensitize the population?
Well, we have been working closely with the Ministry of Education in this regard. The health and family life education component of the curriculum in schools would contain elements of such advisories and improving children's skills and knowledge about the link between improper diets and insufficient exercise and obesity and disease. Recently, we introduced in schools lifestyle health reader, and that now is going to be embedded throughout all the primary schools, and we're going to be doing one for another reader for the secondary schools. And we completed a healthy lifestyle quiz recently, about 3 months ago, and these 2 schools in South got first prize. utilizing this healthy lifestyle reader. So you're absolutely spot on there. We have started working with the school children, and our intervention there didn't start this year. It started a few years ago. In the secondary school children, we haven't prepared any readers for them as yet, as specifically as we've done for the younger age group, the elementary school. So that is coming on stream later on in the year. We have also been engaging with the Parent Teachers Association and educating the principals, so they're all on board with us. So it's a national integrated effort between the Ministry of Health and the Ministry of Education. They are on board with us, and we are on board with them, and we're working very closely.
Now, my final question on this round, may I ask the cost to the population and to the nation of Trinidad and Tobago, as it relates to the amount of resources in a period of scarcity that would have to be diverted towards this drive that we are all seeking to move towards healthy or more healthy lifestyles. But we are fighting against a serious battle. We have a battle that we are up against a wall. On the one hand, sometimes I wonder if ISIS or terrorists, if they were to launch an attack here, if they could get rid of close to 6,000, almost about 3,673 citizens in 1 year perishing because of cardiovascular diseases in Trinidad and Tobago. That is worse than, for instance, we having an invasion here. and I'm asking the question, Doc, what is it costing Trinidad and Tobago's treasury, the consolidated fund, in terms of foregone revenue that could have been diverted into some other measure in terms of health care advancement? That is what I'd like to get clarification on.
Okay. Well, we've had a study commissioned a study last year from the Inter-American Developmental Bank, and they produced these figures for us. They said they have estimated that the economic burden from diabetes and hypertension amounts to $6.7 million. Billion dollars. But for example, the indirect cost for treating hypertension is about 58% of that $3.2 billion. The indirect cost is what you're talking about. That is productivity losses. And I see where you're coming from. So an actual treatment of the disease is 42%, 43 is 12, 40. So it's just under half of 3.2 billion for hypertension. Diabetes, total cost is $3.5 billion annually. Again, it's roughly a little more than half the productivity losses. So that's the framework in which we are operating. It's really an enormous burden on the treasury and on the population. Apart from the suffering and pain and loss of life, is a serious economic burden. So that we are very mindful of it. That's why we are very aggressive in the ministry now, so that I don't think any country could sustain that burden for much longer.
Thank you, Dr. Boone. And therefore, I just want to ask Dr. Budo to just join the conversation at this stage.
Thank you, Madam Chair. And just to follow up in terms of the economic burden and to look at the issue of renal dialysis, and if I could refer you, PS, to page 9. Now, I'm seeing here that we have a figure of 927 for fiscal 2018, to October 2017 to March 2018. I just want to clarify, perhaps Bisham, you could clarify, does that refer to the number of patients or the number of cycles of dialysis? Can we have some clarification on that?
This refers to the number of patients.
Patients, right. Now, in terms of the waiting time for dialysis, can you perhaps explain to us, to the committee and maybe the population, what happens here?
But so therefore, it would be evident that what this is indicating is that this problem is escalating, because if for all of fiscal 2017 we had 927 cases, already we have had another 927 for this period. So it is an escalating problem, and the BMI study for children is not yet out, but we do know that we have a 25% of our children are already obese. So the problem has been growing exponentially over the last 15 years or so, in tandem with the economic development of our country, regrettably.
Yeah.
So
I noted that you've already spent $12.9 million on dialysis, and you'd be presumably having to seek more funding for the rest of the year.
Yes.
But I wanted to come back to the issue of emergency dialysis. Bisham, perhaps you could give us an idea of how that is taken care of.
Once someone presents at a public institution, healthcare institution, and requires to be dialyzed, they are dialyzed. Over the weekend, for example, there's a patient who presented at San Fernando with end-stage renal failure with creatinine of 23, I believe it was. And over the night to the next morning, they were able to actually put in the fistula, a temporary fistula, and have him dialyzed on Sunday morning. So there are situations where we are able to do it in the public sector and treat with emergency cases. Patients who require hemodialysis, once it is they go through the public system, they are dialyzed at all of our hospitals. Once the capacity is reached, we then start sending them privately. We are in the process of trying to expand all of our renal wards at our public hospitals to meet this growing demand. But at this point in time, patients get access to service both at the public institution and the private sector.
Can you give us a sense of the capacity of the public sector in terms of the number of dialysis chairs that would be available at each of the major institutions?
I would have to provide that for you, Renal.
Can you provide that? Can you at this point state which institutions would be providing dialysis?
Currently, we provide dialysis at all of our major hospitals.
Would that include Sangre Grande as well?
That includes Sangre Grande, correct.
Right. So you're talking about Port of Spain, Mount Hope, Sangre Grande,
and San Fernando.
And San Fernando.
Yes.
So we spoke about end-stage renal dialysis, and we know that sometimes the treatment for that CMO would be a renal transplant. Are we in any position, do we have any provisions for looking at a renal transplant? I know we have legislation in place for organ transplant and so on. Would you want to expand on that a little bit for the benefit of the public?
Many thanks for that question, through you, Chair, and many thanks, Dr. Bodo. Actually, we were speaking about that just before, and I'll direct it to Mr. Jaising, who would give you the answers.
Hi, good afternoon, Chair, member as well. Thanks for the question. To date, in 2018, we have done 6 transplants to date. From the inception of the program to now, we have done 174. It's really about an average of 15 per year. From 2006 to 2018. There's also a provision in the PSIP to increase the scope of it as well, to look at more disease-type donors. So we are looking at that as well in terms of expanding that scope in the facility of providing equipment, training. But the issue has always been the donors, basically.
What challenges are you facing specifically in terms of that?
In terms of the communication strategy, in terms of how do you source donors for the program, and also building capacity within the program as well to ensure that once you get the donors, you have capacity built to ensure transplants take place. So it's really looking at the whole issue of increasing capacity to some extent in terms of the demand and supply issue.
Is there any public education system or any system in place to educate, sensitize the public?
Just through our website as well. There's Public Uniform on Facebook. But there's also discussions in the ministry of increasing the capacity, as you mentioned, on the cardiac for renal in terms of increasing the shift system in our public side facilities as well, where there's a need to actually expand the scope apart from 8 to 4 to use those facilities. So these are discussions right now on the ministry in terms of increasing that capacity in the public system.
So currently you're not in a position, for example, to do a transplant with a cadaver organ that might become available during the night or something like that?
There's capacity in terms of that, but the assessment and also the referral side of it and the approval, probably that should take about a couple of days. But again, I know CMO, in terms of your knowledge, in terms of the timing of the transplant, I don't know if you know.
I wouldn't have that specific information at this point in time.
All right. I just wanted to ask with regards, now I know there were plans in place to build 2 renal dialysis centers, one in Mount Hope, one in San Fernando. Can you provide us with an update, PS, as to what is the status of these 2 proposed centers?
I'm sorry that I can't comment on that because it is now a legal matter. But so that's as much as I can say with respect to
both centers are tied up in a legal matter. You're saying that both centers are tied up?
Yes, I am.
All right. Fair enough. Chair. So there was one more issue, and this is with regards to the providers that have been selected, for renal dialysis for outsourcing. And PS, you mentioned that the barriers to entry are low, and I'm a little bit concerned about that because I know that some of the patients develop complications. So the question I want to ask is, first of all, whether there is something like a complication register that is kept at the ministry, and of course, that will be populated. The data will come from if I understand it, after dialysis is done by outsourcing by a provider, the patient comes back to the hospital where they are dealt with by the in-house doctors. So do you have a system in place where any complications that occur as a result of outsourcing, I'm not talking about in-house, are registered, and does that come to your attention?
Mr. Sita?
All complaints are sent us and they're investigated. And you're correct, member, the patients are seen at the public institutions, and once there any complications, it is brought to our attention. What we try to do is manage quality. We have over the last few years, tried to enhance and improve on all of our quality service delivery. So we actually engage on doing ad hoc site visits. We do planned site visits. We called patients randomly. We visit patients at the public hospitals as well as the private centers to try and get an understanding of exactly the quality of care that's being provided. All of our nephrologists within the public sector do report back to us and tell us exactly what their findings are. They tell us should there be any sort of concern, it is escalated to us and it's dealt with.
So you say that there is a mechanism in place for the doctors in the hospital to report these complications directly to the ministry?
Yes, there is.
So based on that, I mean, do you do an assessment? Because you have several providers, I noticed, quite a number of providers for a small country like ours, but I wouldn't comment further on that. But in terms of identifying, are you able then to identify whether there might be shortcomings with particular providers? Do you do an analysis at the end of maybe a 6-month period or a 9-month period, or even a 3-month period, because waiting 6 months or 9 months might be too long? If one provider is having unacceptable complication rates.
What we do is we actually do quality assessments of all of our providers within 3 to 4 months throughout the year. We include members of the RHA, members of our quality team, a nephrologist or senior medical doctor, a dialysis nurse, as well as our county medical officers of health. What we try to employ is the same principles that apply for a private hospital, so the quality of care is of that standard.
So the standard that you use to engage the providers, are they international standards in terms of renal dialysis? Can you tell us?
Yes, they are. We actually provide a standard operating tool for hemodialysis to all providers, whether to provide to the Ministry of Health or to provide independently of the Ministry of Health. We provide the standard tool that's provided. It's also available on the Ministry of Health's website.
You spoke on page 24 of your submission. You speak of the inspection teams. I may have missed it, but did you mention what these teams comprise, who are the members of the teams,
Yes.
and what they would look for when they do the inspection?
The teams actually include a nurse and a doctor within the specialist field. In this case, in renal dialysis, we ask for a nephrologist or a senior medical officer. We ask for a member of the quality team of the RHA, a representative, a biomedical technician from the RHA, our county medical officer of health. The team is in essence a membership of 5 to 7. They look at not only the patient care, but they look at all logs, utilization, the machines. They try to encapsulate the entire process from beginning to end and then report back.
And these inspections are done how often?
The inspections are done mandatorily every year, and we try to do it at least 2 or 3 times apart from the mandatory time period.
And you spoke about you spoke about the equipment being certified yearly. Who does the certification? Can you define what is meant by certified? Who does it? How is it done?
I think the equipment that they would allow or that they would be using would be the standard. The equipment that they would be using would have to have met certain standards, and it's from that perspective that's one of the element of the standards that apply and the certifications that apply with the equipment. Those standards are set by the discipline, for example. If we don't have our own standards, we would adopt an international reference agency standards. So that's how, and they're benchmarked or they're reviewed based on those standards. In terms of the maintenance of the equipment and making sure that they're calibrated, for example, that is the responsibility in-house of the facility. But when the team goes out, that is what is inspected to make sure that they would have complied with making sure that calibration would have happened and certification if necessary.
All right. I just wanted to let us look at the list on page 25 and 26. 2 questions there. One, I noticed that Sinclair Medical Center would have withdrawn their service in December 2017. Can you indicate the reason for that?
Sinclair Medical Center would have withdrawn their services because of delayed payment for services rendered.
There wasn't any issue with
No.
standards and so
No.
on. So can you then give the public the assurance that the remaining 17 centers that provide dialysis to patients in Trinidad and Tobago meet all the standards as required by the ministry and meet international standards?
We continue to do checks. Actually, at this point in time, we are going ahead and doing checks on all of our centers at this point in time as well.
Might I just
Yes,
ask when
sorry.
last was equipment checked for calibration?
All centers were checked at the beginning of January this year, between January and the end of February this year.
Were any found to be defective under the standard in default?
No.
No.
So can you, sorry, Madam Chair. So can I then have a straight answer to the question I asked before? As to whether you can give the public the assurance that all of these 17 providers meet the requirements?
Based on checks performed over the last couple of months, yes. And as we continue, we would try to improve on the quality of care.
Thank you.
So how many have been checked?
All have been checked.
No, you said up to January, and you see it currently in the process now. How many in this current cycle have you checked of the 17?
But all 17 are being checked at the same time.
Or so you haven't completed the checks?
No.
So you could say as of January 2018,
Yes.
all have been compliant?
Yes, correct.
Okay. Member Raful.
Thank you. I really appreciated the information about NCDs and the cost thereof to the economy of Trinidad and Tobago, and of course the quality of life and well-being. I'm curious to learn more about the preventative methods that are being looked at. I do expect that might be outside of the scope of this particular unit of the ministry, but I'm curious to hear the PS's perspective on what other programs are being done by other units in the ministry.
Well, again, I'm going to point you back to Dr. Doon, particularly with respect to the NCDs. But what we have done is we have engaged on a project with the IDB, which is a $51 million US dollar project that is going to be focused over the next, well, it's now about next 4 years on primary healthcare but specifically within that, the control of the NCDs. And much of that is going to have to do with bringing about a culture change within within our nation. Some of it, of course, will be determining the measures, doing benchmarks and baseline studies. Dr. Doon mentioned already that one of those studies will be a BMI study of the population, but there will be other studies. And then a range of projects will be devised over the period to bring that problem under control. It is really a black hole. The more money you pour into it, the more money you need to pour into it if you try to deal with it at the end stage. So we have to try to get at it at the early stages, our children, teenagers, and prevent the development of inappropriate behaviors and eating habits in particular at that age. But perhaps you would like to speak a little bit more about the project.
Well, there are four broad priority areas we've identified. One is risk factor reduction, and that is in its broadest scope at every level and for all members of the population, from childhood straight onwards to adult and life. As you know, the risk factors for NCDs are very common. So if you could really reduce the frequency and prevalence of risk factors in the population, you're going to be able to reduce the prevalence of a bunch of diseases, namely cancer, hypertension, diabetes, heart disease, as I would like to call it and describe it. Since we have bad eating habits and smoking and drinking, to me, NCD is a hand-to-mouth disease. So if you could control that access, we're going to make a big impact. And so behavior change, as you know, is one of the mechanisms that we are working through. So we are going to be engaging shortly a firm to help us with social marketing, because we realize that the business community could market their products, these foods that, you know, we wish not to be consumed in the frequency and volumes that we do, these unhealthy foods. So the ministry do not have the resources right now to go into a national social marketing campaign. So we are addressing, we are utilizing a settings approach. For example, the school setting. For example, the health center being a healthy focus, community setting. So that's a broad thing for risk factor reduction. The other major priority area with a number of activities would be surveillance and research. And so the PS spoke about that, is establishing a risk factor in the population, the prevalence of risk factors in the population in general. So that's for the adult population. We've just finished in the school population. And for the adult population, 18 years to 65, that will be conducted next year. But judging from our previous studies and risk factors in the population, we have observed, take for example, overweight or obesity. It's in the region about 55.7% in the general population, and it's more prevalent in women than men. Inactivity is more prevalent in women than in men. But of course, smoking and alcohol more prevalent in the males than females. So that's what we intend to track. This study was done about 10 years ago. So we're going to track next year what is the prevalence of risk factors in the population. So we will get an idea of whether the interventions we are making is working, how effective they have been over time. So that's one of the most important measures any country must work with. The other main area in the research and surveillance component is to establish registries for diabetes, heart, so that you could get data every year on time, how many heart attacks every year, how many strokes every year as it happens. That is not yet available because of the inability to establish electronic medical records in the country. So we have to do it the hard way by counting using the paper-based and manual data sets. So data is always going to be a few years late because of the environment in which we work in. So that's a major component. The other major component is advocacy and policy. So we're creating policies. We are obviously, you're going to want to go into legislation like the no smoking legislation, but you have a whole host of other legislation and policy instruments which need to be established. So we're working on that. And then the fourth, sugar in schools. And the fourth major priority area is the health sector response. How do we improve what we do in the health sector? How do we deliver the service? And as Dr. Boda has been talking about with the failure to communicate, one of the side effects of the health sector reform has been, and it's not only in Trinidad, but throughout the Latin American and Caribbean region, which is a PAHU conducted study, they found out that fragmentation arose because of the decentralization and the unexpected and unanticipated side effects, bad side effects, as you see, which has happened here and has happened in every other country that engage in health sector reform. So those are the four main priority areas and a bunch of activities. And as I mentioned before, it's a whole of government, whole of society. So we are building partnerships with the private sector, building partnership with the non-governmental organization. And we do have a national NCD alliance formulated in Trinidad, established last year, which the ministry started and engaged with them. And now they are on their own. So it's all of us in this thing together.
Yeah. Thank you,
Parents,
Dr. Dubois.
communities,
Dr.
and individuals.
Doon, I don't really want to cut you, because I think what you have really presented us with is also some assurance that there's some risk reduction being looked at. Because I think the point was made by the PS that it's always going to take money, and therefore the more you're putting in front, the less you'll have to at the end. And I think the initiatives you've spoken of suggest that that is well in tandem. But having regard to our limited time, we could spend the whole day. And believe me, I'm sure there are other questions that we are going to put to you, even if not today, but in writing, but to give the other members here from the other aspects of the special healthcare an opportunity to speak. I just really wanted to steer us in another direction. And Member Raful, I'll come back to you. Might I just invite Member Olivier to join the discussion?
Thank you very much. In your response on the administration of the special healthcare programs, particularly the adult cardiac disease and the renal dialysis programs, you indicated that if a patient requires interventions that are beyond the capacity of the public hospital, or the hospital cannot accommodate the volume of patients, you would engage a public-private partnership, but you would require the patient being assessed by a medical social worker. So my question is, who engages the medical social workers? Is it the RHAs or the Ministry of Health? And do you have adequate medical social workers on staff?
To answer the second question first, yes, we do have an adequate number of medical social workers, and the doctors refer the patients to the medical social workers. They are actually located at all of our major hospitals, so the patients don't have to go very far to be assessed.
Okay, who engages them, the RHA or the ministry?
The RHA.
Now, as an elected member, I do have constituents, and a number of them would have engaged me because they are having to wait inordinately long time to get services by the hospital. And in a number of cases, I mean, they're waiting for a review by the medical social worker. And from my understanding, they would tell me that the person comes once a month to the hospital. So in a number of cases, I had a case of a young child, maybe about 7 years old, who required surgery on his eye because there was silicone oil in his eye. And that case went on for about 1.5 years before he was able to get the surgery. And the child practically went blind, and that I had to miss school. The child's behavior started deteriorating because of the lengthy time just to get that simple surgery. And in that 1.5 years, the condition escalated, significantly. So the child finally, through the intervention of the chairman of the Southwest Regional Health Authority, I was able to get that done finally. But the issue with the medical social worker was cited in that case, and I had another case of an adult male requiring some heart intervention over 1.5 years now, and that case still has not been addressed. And again, the medical social worker having to assess the patient and that person only being coming to the hospital once per month. So this is why I had to ask, do you really have adequate medical social workers? These two cases would have been with the Southwest Regional Health Authority, the San Fernando General Hospital.
Member, if I can answer the issue with Southwest Regional Health Authority, at the San Fernando General Hospital, there are social workers there on a full-time basis. However, in Point Fortin, they have medical social workers who go part-time. That issue is being looked at and being addressed to ensure that that does not happen again.
Well, just for clarity, these two cases were at San Fernando, not at Point Fortin. But the other question I'd like to ask, well, on the HIV/AIDS program, can we move on to that now? Yeah. Oh, sure, yeah. If I may ask you about the administration of the HIV/AIDS program, who is responsible for education from a standpoint of prevention?
The Ministry of Health, through HACU, is responsible for providing education, information to the population.
Do you have any active programs ongoing to enlighten the program from a HIV/AIDS prevention standpoint?
Yes, we have a number of programs that are ongoing, and we also collaborate with the NACC as well. That is the National AIDS Coordinating Committee with respect to our prevention programs. We also work in conjunction with the Sexual and Reproductive Health clinics, and that particular program is part of we collaborate with them as part of our prevention initiative.
In terms of your outreach initiatives, what type of target markers do you have? Do you have a program that targets like schools in particular, or how do you decide when and where to launch your initiatives? Well, the reason I'm asking is because I am not aware of any large amount of HIV/AIDS prevention programs in recent times. And HIV/AIDS is something that it's a latent epidemic in certain parts of the country, but something that's not spoken about. It's not in the public domain. And I'm really not aware that there's any active prevention program that is currently undergoing. So in particular, I mean, are you targeting perhaps the schools or any other segments of the population for an education campaign?
We do target, we have some programs that are going on, not necessarily at the level of the primary schools and secondary schools, no, but at the level of the tertiary institutions, we would have some prevention programs there. We'd have community-based programs. We'd have at institutions such as the prisons, for instance. We also have particular days like World AIDS Day, Caribbean Testing Day, when we would heighten our program to the general public.
So if a NGO or some organization would like to have a specific program run, I mean, can we contact you to arrange something?
Certainly can, and our function would be to work in collaboration with NGOs as well that provide prevention initiatives.
All right, thank you very much.
Member Mark.
Thank you, Madam Chair. Permanent Secretary Marjorie, in your submission, we were told that there was this private-public partnership arrangement for joint replacement cancer care services and even cataract surgery. Would you like to share with this committee the state of the private service providers? In other words, who are these private service providers and what services do they actually provide, given the three areas that you have outlined joint replacement, cancer care services, and cataract surgery?
Our external radiation, which is our cancer care treatment, we utilize 2 service providers, the Brian Lara Cancer Treatment Center and the Southern Medical Clinic. These are the only 2 private facilities in the country that can provide radiation therapy. With respect to the joint replacements and what was the other?
Cataract surgery.
Perhaps you could respond. Mr. Sitaram.
With respect to joint replacement cataract surgery, we actually have several providers, which I'm willing to share with you in writing. Because there are several, and they're spread across Trinidad.
All right. Well, I'm happy that you can provide us in writing, but may I bring to your attention that we had recent reports, which was confirmed by the chairman of the Northwest Regional Health Authority, in which there was an allegation, maybe you can confirm it, to the effect that an investigation was launched into what has been described as a mismatch between parts as it relates to joint replacement that caused some state of alarm. Could you provide this committee with an update on this development?
Madam Chair, through you, thank you very much for the question, member. The NWRHA is currently assembling the report, the final report on that matter, and we are awaiting the final report. However, what we would like to report to the committee is that they have actually taken steps to strengthen their process or the procedures along the lines of how do you go about identifying suppliers and equipment. So, for example, all suppliers for these particular equipment, they were asked to provide verification of the quality standards of their devices and to ensure that those standards will meet those of an international, recognized international body, for example, the FDA or another one of equal standing. They have written, so that's one of the information, that's one of the measures. And based on that, now you can be assured of the standard of the devices that will be coming in by the suppliers. They're also adopting an approach whereby the expression of interest that is also regulated in a sense, the anonymity in terms of the NWRHA practitioners becoming involved in that process. And then they are engaging in a process to ensure declaration of conflicts of interest with the providers and suppliers, with the practitioners and suppliers. So those are measures that will definitely strengthen the process to ensure the quality of the devices that are used in such procedures, but the report is currently still being prepared.
More generally, the ministry is engaged in a process, generally speaking, of strengthening the procurement process, not just within the ministry, but also the RHAs. So bringing practitioners together, we are hoping will enhance that process.
Yeah. Would you want to also share with this committee what would have been the situation involving, let's say, patients who may have undergone surgical procedures in the recent past, given that experience that we had at the Northwest Regional Health Authority, and what mechanisms have you put in place to monitor those patients who might have been victims of mismatch parts? Let's assume that would take place. How are we monitoring to ensure that lives are not at risk?
So one of the measures which I forgot to mention is that they're actually doing that. They're reviewing those patients within a particular period of time. I don't have that particular period of time with me, who would have undergone procedures, and so following up to see whether there were any effects or complications of those procedures. So that is something that is ongoing right now. The report and the assembly of that information I don't have right now to share, but it is a process that is being engaged in.
And could you indicate to us what is the current state of hip surgeries? Have they been stopped since this expose, or have they continued? And what safeguards have we put in place to ensure that that incident that took place would never recur, pending your report, that is?
Yeah, I would rather that be provided to you in writing to get the most recent information from the NWRHA, so you can get a specific answer to those questions.
May I, Madam Chair, as I'm on this matter, may I just ask my colleagues here if they can share with us this whole matter of AIDS that was raised by my friend. There is an NGO that we need to get some clarification on. First of all, why is the Medical Research Foundation of Trinidad and Tobago not listed as one of the non-profit organizations in the budget documents? Why that body is not listed? And could you tell us at the same time, under what sub-item is the subvention to this organization covered in the terms of this AIDS program, AIDS, HIV? Who can help us with that?
I'm sorry, I'm going to try to address the first question. I know, well, I don't have the budget documents in front of me, but I do know there's a section in which the NGOs are listed that are receiving funding from the PSIP under the current so all the NGOs are there. Sorry,
all right,
I can't explain.
All right, but could you tell us, Mr. Pierce, what is the subvention that this organization would have received or is receiving in fiscal 2018? You should have that with you.
Mr. Jai Singh will respond with the precise figure.
Thank you, Member, for the question. Just to answer your initial question, on the special program HIV, on the PSIP, MFTT was actually an item there. What we tried to do over the last 2 years with Ministry of Finance was to relocate MFTT under non-profit organizations, generally under recurrent expenditure. So it shifted during fiscal year 2018 from PSIP to recurrent expenditure itself. The second question, in terms of the amount of funding annually, it is 5.9 million per year. There's a 3-year subvention, basically, that we initially got, and it's arranged through an MOU with the Ministry of Health and MFTT, through cabinet approval, of course. And we recently got approval from cabinet with all NGOs, including MFTT, from 2017 to 2020.
And Mr. P.S., how does the ministry go about monitoring the expenditure released to this organization, and by extension, how is the accounting oversight role of the permanent secretary executed as it relates to subventions granted to non-governmental organizations?
With respect to MRFTT, as well as other NGOs, there are memoranda of understanding that are signed with each NGO in which the services to be provided are laid out, and the amounts to be provided by the ministry are also laid out. There are reporting requirements in each of those MOU, the specifics of which can be further detailed by Mr. Jai Singh, who is the director responsible for that particular function of monitoring.
Maybe you can provide us with just one or two of the specifics, and could you submit to the chairman a copy of the MOU that you mentioned?
MRFTT, sure.
That govern not only the MRTT, I think, MRFTT, as well as other NGOs, okay?
Sure.
I don't know if it's one common MOU or you have separate MAUs with separate criteria for all of the NGOs, along with the one that I mentioned earlier.
Sure, there would be a general template, but there would be specific requirements.
Well, could you provide them to the chairman on behalf of our committee? And maybe our colleague could just give us one or two specific ingredients contained in the MOU. Just one or two.
Sure. Mr. John.
Thank you, Member. In terms of the MOU, the obligation side of it, quarterly assessment is being done on each NGO itself with the assessment team, chaired by the CMO, and also they have reporting obligations. And in the MOU, there's specific criteria. If there's non-reporting of reports, we withhold the subvention until we get the actual reports. So that is one, and we are assessing not only the financial side of it, but also the operational management and HR capacity to deliver the service as well. So we have broadened the criteria, not only from a financial, but non-financial areas as well. And also there are obligations in terms of the actual assessment of the service as well. And that is mainly the obligations from the NGO side in terms of meeting our criteria for assessment.
Thank you, Madam Chair.
Okay, Member Raful.
Thank you, Chair. I had a follow-up question about the prevention programs. There's a financial instrument called Health Impact Bonds. They're like PPPs, public-private partnerships, but specifically health-oriented, and I would just recommend that the ministry look into them. They're relatively new. They've only been around for a few years, but having really significant positive impacts internationally where they are being implemented. So they're a mechanism for cooperation between public sector and private sector that really defines targets beforehand and is all about results and achievement for the population.
Thank you for the suggestion. We will take it on board.
Thank you. Member Boudou.
Thank you, Madam Chair. PS, just a quick follow-up on the HIV treatment. In terms of the funding, I understand that there is an organization called PEPFAR that we get some funding from in Trinidad and Tobago. Can we have an update as to what is the status of that relationship? Maybe you can explain for the benefit of the public the entity that's involved and the funding that comes from that source.
The Chief Medical Officer will respond to that question.
So currently, my apologies. Through you, Madam Chair. Currently, we have entered into another agreement. We previously entered an agreement in 2010, and that ended in 2017, and so we entered a 2017-2022 agreement. We have engaged in the first 2 years of that agreement, 2017-2019. Fiscal year 2017-2018, we have managed to, the funding that was received for that was $275,000 US. What is projected for fiscal year 2018-2019 is $205,000 US. So first I'll deal with 2017-2018. 2017-2018, we are still in that fiscal year. We have there are three elements of it. There's a prevention work plan, a strategic information work plan, and a laboratory work plan. And there are a set of activities under each of these work plans. The prevention work plan activities are engaged through the MRFTT, and that sum was $125,000 US. And that sum was sent across to MRFTT. And Dr. Edwards can speak to specifics as to what those activities are involved. And it comes back to Member Oliver's question about education and the focus to retain, to offer testing and to retain patients within care, and the numbers that Member Raful also spoke to. So Dr. Edwards may shed some light on that. The strategic information work plan and the laboratory component work plan, they involve the recruitment of viral load laboratory coordinators, surveillance nurse, M&E officers, and that is a process, 2 of which have actually been directly engaged in. The M&E officers, they're scheduled to come into being, the interviews next, I think, 22nd of May. But that process is a transparent process, a process that includes the CDC, because the CDC is the donor through which we receive the funds. And so they are engaged in that process. It's a transparent process, as I said. Those bodies are to engage in doing laboratory strengthening, for example, and there are a range of activities under laboratory strengthening. In terms of surveillance, there are the surveillance capacity for HIV/AIDS case-based surveillance, a particular approach to surveillance for HIV, and the entire the data surrounding, because some of the numbers that you saw in that table, 82,000 or so, if you look at the title, I think the title spoke to healthcare utilization. And one of the challenges that we have is the representation. There's number of, for example, tests performed. One person may have multiple tests. So harmonizing and trying to identify how many unique persons were tested as opposed to the number of tests conducted. So that's what the 2017-2018 work plan is about. The 2018-2019 work plan, the CDC Caribbean Regional Office came down to Trinidad, and we had a joint meeting with the HIV/AIDS Coordinating Unit team and the CDC regional team, and we agreed on what would have been the activities under the 2018-2019 work plan.
Sorry, Doctor, perhaps maybe you could provide that in writing for us.
Yeah, we can share those.
I thank you for that. But just to clarify, that this is a grant.
Yes.
It's from the Centers for Disease Control. It's from the U.S.
It originates from the PEPFAR fund and is managed through the Centers for Disease Control.
Right. So in terms of the disbursement and the monitoring of the disbursement of the fund, does that come under you, PS? How is that? In other words, how are those funds accounted for and monitored and disbursed?
Yes. Well, I'm just noting that because of this arrangement with the U.S. government, there's a particular interest in ensuring that the goals that are being laid out, which we share, are in fact achieved. The unit that is managing the arrangement with MRFTT, or the units are both between policy, but primarily the HACU division. So the HACU will be monitoring whether those funds are being utilized and the results that we need to achieve in terms of generally the goals are our 90-90-90 goals. That is that.
And that would lead me to my next question, which would be, what is the relationship between the HACU, as you call it, and the National AIDS Coordinating Committee?
So can I ask Dr. Antoine if you can elaborate on how operationally those arrangements occur?
Thank you. The National AIDS Coordinating Committee is really coordinates a number of our multiple stakeholders in the national AIDS response, of which
That's a unit that would have been moved from the Ministry of Health to the Office of the Prime Minister.
To the Office of the Prime Minister. And of course, the HACU is one of those stakeholders that is responsible for the health response or the medical response. Yes.
And that has been working fine.
You mean in terms of the relationship?
In terms of the relationship.
Yes, well, it's a well-defined relationship that we have. HACU is responsible for that multi-sectorial response, and the Ministry of Health, through HACU, is in fact one of the stakeholders in that response.
Right.
I would just like to ask Dr. Pratap Singh if he could add to that response, please.
So to attend to the accounting, with regard to the accounting matter, there is an officer within the HIV/AIDS Coordinating Unit, HACU, who is dedicated to managing and doing the accounting. The relationship between MRFTT, HACU, and CDC is an intimate one that we meet regularly virtually. And in there are budget requirements, there are financial reports that need to be submitted every quarter. They're reviewed by myself and PS. So the accounting and the measurements, the measures that are put in place to make sure that funds are used for what they were targeted for are there. The relationship with NAC and HACU, HIV/AIDS, I mean, you know, Dr. Bodo, it's such a multi-sectoral, multidisciplinary approach, and I think it is one of those that has historically been able to be assembled in Trinidad and Tobago. And I don't think any inactivity happens or takes place without interaction from NAC and HACU, whether it be by way one initiating and the other following, or collaborating at the same time. But the relationship is an ongoing one, it's an evolving one, and it's one that's present.
Sure. Can you, CMO, give us an indication of perhaps the number of patients who are currently confirmed with HIV/AIDS in Trinidad and Tobago?
So I will defer to Dr. Edwards and Dr. Antoine. They can give you that. Just to note that the MRFTT is the largest treatment site. We have treatment sites. There's one in San Fernando, Port of Spain, MRFTT, and then there's a treatment site in Tobago. There are other testing sites which are larger in number. And the reason why MRFTT has been recognized is because of the success that we have been able to, because it's a model of care, and there are reasons why persons living with HIV come to the facility. So I'll pass you over to Dr. Einstein and Dr.
Okay, so the Medical Research Foundation was founded by Professor Bartholomew in 1997, and in 2002, the government of Trinidad and Tobago commissioned the MRFTT to become the first HIV/AIDS site. Now, you know, HIV/AIDS now is a chronic disease, so people live a fairly normal life. So if you have HIV now, your life expectancy is almost normal. And the antiretroviral drugs, the medication that we give, what it does is suppresses the virus. And when the virus is suppressed, you don't transmit. So UNAIDS has this goal of 90-90-90, whereby 90% of persons should know their status. 90% of those persons should be on the medication antiretroviral therapy, and 90% of those persons should have their viral load suppressed. And they expect if that has occurred, they can eliminate HIV/AIDS by 2030. So HIV/AIDS, things have changed dramatically, and for the public, HIV/AIDS is no longer a death sentence. You can live a normal life. And at the Medical Research Foundation, what Dr. Patap Singh was talking about, we have extended hours of the clinic. We normally had clinic hours between 7 and 4, where we realized that a lot of people weren't accessing therapy. So working in collaboration with the CDC, we have extended the hours now to 7 p.m. so that people who are working can come and access it. So, because it's most important for people to take the medication to suppress the viral load so that they don't transmit.
That's good news, but any idea of the numbers?
Total enrolled in HIV care at the end of December 2017 was 8,530 persons, and the number of children and adults currently receiving ARVs was 6,693, of which 746 were newly enrolled in December, by December.
If we were to go back 10 years, and I know you may not have the figures there, or perhaps you might, in terms of where we have come from perhaps 10 years ago. Can you give us some sense of that from a statistical point?
We would have seen, in the early days, 10 years or prior to that, we wouldn't have treated all positive cases, all right? And there were certain benchmarks, the CD4 counts, that defined whether someone should be placed on treatment or not. I would say from 2016, 2017, we have embarked upon a treat-all, so that you would have gradually seen a rise in numbers of persons who are being treated. And of course, you would also may have seen a rise in the number of persons enrolled in HIV care as well.
I just wanted to address the issue.
I just wanted to clarify the number, the 82,000. The 82,000 may not have been a typo, but I didn't quite grasp the point that you were trying to make, and it would represent the total number enrolled in care, plus those persons who have used our testing services. Yes.
Yeah. If I may, just one more question with regards to,
which the point has already been made that our testing service, the numbers for testing, roughly 75,000, of course, does not represent persons, but tests.
Yeah.
All right, and we are working currently, have a system where we are attempting to deduplicate so that we can reduce tests to number of persons tested.
Okay, I know Dr. Buddha has a number of questions. I just want to remember, Antoine has been waiting for some time. Do you still have the question to ask? So I'll allow you in, and then I'll take member Oliver. Member Antoine?
In terms of cataract surgery, I saw in fiscal 2017 you had 361 surgery, but in fiscal 2018 you only have 91. Any reason for this drastic reduction?
These are the numbers that would have been sent to private institutions. So the reduction is based on the fact that we are now ramping up our services out of public institutions. So as we increase our public capacity and our ability to provide the service in the public sector, the numbers would go down.
So these figures are for the private?
Private, correct.
All right, in terms of eyeglasses, in fiscal 2017, you had 632. In 2018, 300 applications received pending approval. What's the reason for this pending approval for the eyeglasses?
The pending approval being the availability of funding. So what we have already requested funding to have these glasses purchased. And once we receive it, the process is less than 5 days to get glasses dispensed.
So the money is available now?
We are sourcing money right now.
Going back to the HIV, is there a reduction in cases of HIV in Trinidad and Tobago? Because I saw recently they said that
newly diagnosed cases?
Newly diagnosed cases.
Yes. The trend has been towards a reduction in the number of newly diagnosed cases over the last 10 years.
Because I read somewhere or heard on the news that it seems that men over 60 and young females seems to be a high case incident of HIV in Trinidad and Tobago. Is that factual?
Yes, that is also correct. In terms of the age distribution of the number of cases, as opposed to the number of newly diagnosed cases. So in terms of the trends, there are trends towards a reduction in the number of newly diagnosed cases. That would probably tell us that our prevention efforts are probably working very well. And in terms of the age distribution, we are seeing some significant numbers within that age group that you mentioned, 50 plus age group.
Because people are living longer, so.
Oh, that's
the aging with it, yeah.
People living longer?
Longer, so the aging with the HIV, yeah.
Another question. A schoolmate of mine recently came to see me because his daughter is a graduate medical officer who has difficulty in finding employment. There's an article by the minister says that part of the problem is in terms of location with the young graduates not wanting assignment in rural areas as the case may be. What is the problem in terms of employment for young medical graduates in Trinidad and Tobago after they finish their internship?
Well, remember, would this be in terms of maybe the program? Because remember, our mandate here is with respect to the special healthcare program. So that if you could maybe rephrase your question so it comes within the context of the mandate.
Mandate special program. Yes. So can we absorb medical graduates in terms of the special programs to alleviate the problem in terms of employment?
Well, I will attempt to field it. The graduate doctors, what we tend to need for these specialist programs are, in fact, specialist doctors, whether it's cardiac and specialist nurses, etc., whether it's cardiac, cataract surgery, etc. So until they specialize.
Okay. So in terms of this program, is mainly specialists that. Okay.
Member Oliver.
Thank you very much. If we just go back to the HIV/AIDS administration, because you've just presented some interesting statistics. I'm sure the population is probably abuzz with one, analyzing what you just indicated. Now, the question I wanted to ask is, well, what has been the rate of new infections, well, that comes to your attention over the past few years? You indicated the trend has been reducing. So what, do you have a percentage on the rate of new infections per year?
Yes, indeed. Thank you very much. The rate of new infections has shown the trend has been towards a decline, and I'm just looking for the numbers here. And from about 2010, we were looking at roughly 1,000 or over 1,000 cases, new cases per annum. And in 2016, the numbers would have been under 500 cases, new cases.
Oh, well, yes. That certainly is encouraging.
Yes.
You were indicating the age distribution of persons living with HIV/AIDS.
Yes.
You indicated that it's among males, the majority is in over 60. Is that what you said?
Not the majority. There may have been some insignificant numbers, which was not expected in that age group over 50, you know, and that may be an indication that one persons are living longer with the disease, so that because of the treatment and care that they receive. And it may also indicate that there may be new cases as well amongst that age group.
Would you have the statistics that indicate the new cases? Do you have that broken down in age groups and gender?
No, not at hand, but that can be provided.
Yeah, if that can be provided, right. It would be interesting to see what the trends are for new infection, if there's any particular age group then that we need to target specifically for our prevention programs. So that information would be useful.
Yes.
Yeah, and thank you.
Member Mark?
Yes, thank you very much, Madam Chair. I want to go to the issue of your CDAP program. I saw where between October 2017 to April 2018, you spent some $32 million. Would you care to share with this committee, firstly, what is the total allocation, Mr. Pierce, for CDAP drugs, pharmaceutical products, that is, for fiscal 2018?
I have the figure for 2017, which is approximately 55 million, and I believe that the figure is approximately the same for 2018.
Right. Could you share with us why it is there appears to be a persistent shortage of drugs, pharmaceutical products on the market through these pharmacies when the vulnerable, the poor in particular, really access those pharmacies? The constant refrain is not available, not available, not available. Could you share with this committee what is happening with crucial drugs that poor, vulnerable people require when they go to these pharmacies?
Member Mark, might I ask if you're relating this to the CDAP program?
Yes,
you're talking about shortage of drugs that are covered by the CDAP program.
Yes, exactly. CDAP drugs I'm speaking about here.
I'll first ask Mr. Jai Singh if he can begin the response, and then Dr. Pratap Singh will also collaborate.
Hi, member, thanks for the question. We have reviewed the entire system in terms of the inventory management side of it, and we realized, yes, there are some instances of stockouts. What we have done as well is to look to see exactly what's the cause of these stockouts, and the issue is really the procurement cycle in terms of the fiscal year allocation versus the procurement of the actual items by suppliers. And while there are some shift in the system in terms of our mislink between the financial and the procurement of inventory, we are looking to improve the system. In the first instance, we are looking at basically there's a reordering of stock every 2 months by each pharmacy. We are looking to improve in that system, maybe to bring it down to 1 month at least, so that each pharmacy will have their minimum stock replenished in 1 month's time. We realize there are stockouts in certain key items. And also from the procurement side, from suppliers' point of view, they are also, because we are a small purchaser, we are at the last end of the replenish cycle. So therefore, we might have stockouts at some point in time. But also, we are looking at alternative strategy to look at the PAHO fund if we could source these pharmaceuticals quicker, faster, and cheaper. We have realized there are some cost savings at that end as well. So we are looking to improve the procurement cycle period in alignment with the financial side of it as well. Because in these instances, normally you look at a 1-year cycle in terms of the fiscal year. So we are looking at alternative strategies, how best we could match the funding availability with as well the inventory side of procuring the items as well. For my department, we have also looked at a tool to actually capture exactly how is drugs procured, when it is procured, when stockouts take place. We actually got the report up to the end of April. So looking at the cover rate of really how we can deal with stockouts and the alternative mechanisms we could put in place to source the drugs accordingly. But it's a procurement issue, basically.
Yeah, may I also ask that under the listing that we received for CDAP drugs, I saw about between 10 and 11 major categories, including Parkinson's, hypertension, among others. Could you share with this committee whether there was more in the past and what we have now is a reduction? Or is this a consistent number in terms of category that you would have covered in the last, let's say, 4 or 5 years, as the case may be? Well, or has there been a reduction?
Well, in terms of the CDAP, how it evolved.
The CDAP drugs I'm talking about.
Yeah, it evolved basically from 2004.
Just repeat first.
It evolved from 2003-04, looking at a specific subset.
Yes.
And this has evolved into different treatment areas, as you saw in our response. It covered about 2 to 3 treatment areas initially. Then it actually increased further to the full 13.5. So looking at from the last 3 to 4 years, it remained on the same 13 treatment areas.
Okay. Could you share with this committee why autism, which is a very prevalent disease among young people, children in TNT, why it is not captured under the CDAP program? Because I haven't seen it. I don't know if I missed it, but I haven't seen a category called autism in terms of pharmaceutical products that would be required by these children and growing adults that would be suffering from that disease. Tell me if I'm wrong. Yeah. I'm not too clear.
Member, if I could pose a question to CMO, if possible.
Through you, Chair, Member, thank you very much for the question. So just to add to Mr. Jai Singh's first to the response, and the change in number doesn't necessarily translate to less availability or less in the interest. What we did is that we are strengthening the VEN list, the vitally essential and necessary medicines. And we are doing so in alignment with what is the best practice, what are those that are recommended for the particular conditions, right? So for example, you might see there's a change in the list of these medicines for diabetes. And that would have been a reflection on reviewing the literature, looking at the evidence, what are the recommended medicines for doing so. So just bear that in mind, that change in number doesn't necessarily translate to availability. In terms of the autism, and now when the CDAP program initiated, it was chronic disease assistance program. And so you find that the evolution has been along the lines of the chronic diseases. Recognizing the duration of life with autism, that notwithstanding that, it's a point to note the burden of autism in terms of relevant to the other conditions and relevant to prioritize the need for the resources, whether we want to have more centralized in terms of the service that is delivered for autism, and so the management of the medicines for those persons. Those are discussions that are currently happening that are in evolution. So that's the situation in regard to the autism.
Madam Chair, one final question. Centralization versus decentralization.
Yeah.
We're looking at C40, which is the major warehouse located in the western peninsula of this country. Could you share with us whether the centralization of CDAP drugs, which is, I understand they have it as some C40 arrangement in terms of location, and its later distribution to various centers, northwest, north central, south, as the case may be. Do you think that, for instance, from the experiences that you have had, that arrangement is generating more inefficiencies than efficiencies, and therefore the costs is one that is problematic given the experiences that we have had under the healthcare system? And maybe we could get some answers or clarification from the Ministry of Health on this particular question. And I'm talking about CDAP drugs here in terms of what are we doing to generate greater efficiency levels in the distribution of these drugs to the various regional health centers in terms of costs.
Go ahead. So I think it might be a better starting. Thank you very much, Member, and through you, Madam Chair, for the question. That's a very philosophical question in the sense of not having looked at the efficiency measures in a true sense or a pure sense of efficiency. From the other end of it, what we can say anecdotally, yeah, we've got the reports and the records of some challenges experienced in the past. But when we look at what we've done over the past year to sort of address that, and I think that's why answering the question with a yes or no is not a right way to approach it, but the way to approach it would probably give it the opportunity to maximize on the potential that it has, and I think that is what the ministry is engaged in. We've engaged in a process, in an activity to track the process tracing, to see what are the steps from procurement all the way down to storage, distribution, at the NIPDEC, at the C40, that central level, at the regional health authority level, and at the end user level. So the entire process. So, and in doing so, we've identified some of the challenges, and some of the challenges, Mr. Jai Singh spoke to some of them, and so we are trying to address that, start the procurement cycle even earlier so that you can really see the potential for this centralized system. There are merits to both a centralized and a decentralized system. The centralized system allows for accountability, management, the tendering process, the review of the tenders, the review of the sort of control with regard to the VEN list, the vital essential list, the farm and non-farm items. You know, that itself is a central function, so it makes some sense, one can argue, for having that C40 still retain that function. I don't know if that answers you at this point in time.
I just want to ask something. In terms of, I've seen it both in renal dialysis and I believe cardiac care. Is there a question of mean testing for people to be qualified?
Yes, both for cardiac and renal dialysis, there's a means test that occurs.
Apart from being a citizen of Trinidad and Tobago, apart from being a Trinidad and Tobago citizen, to get into the public health system, there's a means test, or to get the special health program?
To get into the special program, there's a means test.
And is there qualifying financial criteria?
The medical social workers, after they assess you, they make recommendations to the ministry based on your financials. So there is a criteria. We are willing to share the criteria if you wish.
Thank you. Thank you very much. Dr. Bodo.
Thank you, Madam Chair. Just to go back to CDAP, PS, one of the issues, we looked at the expenditure involved in these drugs on an annual basis. And one of the concerns I'm sure you will have, PS, is that these drugs are dispersed appropriately to the correct patients in the right amounts and so on. I'm sure that you might be aware that there's a practice where, because some patients feel that there might be a shortage of drugs next month or the month down, they have found innovative ways of collecting drugs, meaning that a patient might go to one doctor on Monday, get a prescription, collect some drugs. The same week on Thursday, they might go to another doctor, collect a prescription, go to another pharmacy, and collect drugs. And the following week, do the same thing. My question is really, what mechanisms are in place to ensure that patients do not fill the same or similar prescriptions at multiple pharmacies? In other words, what checks and balances there are to prevent this from happening?
Yes.
I asked this question, perhaps we can relate it. I know at one time there was the issue, there was the suggestion of the implementation of a health card that would have dealt with this problem. So maybe you can keep that in mind in terms of the answer as we go forward.
Sure. Mr. Jai Singh will respond.
Thank you, Member, for the question. Indeed, yes, we are looking at the computerized system known as the health card part of it. Right now, we are assessing exactly the reporting tool of that system, looking at the input, the inventory, and also looking at whether or not the system will fulfill the objectives.
That's the health card?
Exactly.
But what is currently available until such time as that comes on board? What is currently available to deal with this issue? First of all, are we in agreement that this could be an issue?
Well, definitely, in terms of the visibility across the entire supply chain, in terms of the patient's encounter to the stock inventory and to the end patient side of it, definitely there's room for improvement in terms of electronic system, whether it be from EPP, CDAP, across the system itself. And while the health card could serve some measure in terms of looking to see exactly how those objectives can be met in terms of transparency, accountability on the system itself, there's really, is really driven by a manual system at this point in time, with minimal IT requirements.
I hear you, but yes, see, the question is that in terms of the CDAP forms that are issued to medical practitioners, for example, is there some way of tracking where those forms are issued, where they go, and is there any mechanism to prevent a pharmacist or to raise a red flag if the same patient comes to the same pharmacy or a different pharmacy?
I'm not aware of any manual processes that are in place. NIPDEC is not here, and they may have information that we don't have in terms of their interaction with the pharmacies with respect to the CDAP distribution. But I am not aware of this. I do know that we are trying to work with the healthcare system to get a better result out of it.
NIPDEC may not be here, but you are paying the bill, PS,
I understand.
on behalf of the citizens of Trinidad and Tobago. So I'm asking whether the ministry perhaps can look, at some mechanism in the interim until the health card comes on board. Has this problem been studied at all?
I'll say that the problem that you indicated, it's not just that. I'm sure that there are other ways in which, there are other situations in which we would have concerns over whether persons are accessing the drugs or whether costs are being incurred that should not be incurred. And the only way to really manage that carefully is either through a manual system or an IT system. So we thank you for the suggestion, and we will look into it along with NIPDEC.
Yeah, because at the end of the day, you want to ensure that the $2 million you spent is bringing value to citizens of Trinidad and Tobago. I just want to ask one more question with regards to the treatment of HIV/AIDS. and that is with regards to the treatment of children underage. I know in cases where available, you would seek parental consent, but there might be situations where you may not be able to get the consent of a parent or a guardian. How do you deal with those cases?
With respect to cases of HIV, whether as children, of course, the first attempt would be to obtain the consent of a parent. Where there is no parent, for instance, let us assume someone a little older, we would make all attempts to get the consent of the parent. But eventually, we would have to provide treatment because of the ethical issues associated with not treating someone with the disease.
Yeah. In that case, do you have any obligation, legal or otherwise, to report this to the authorities, police, child protection unit, bodies like that?
Yes, there certainly is.
So this is done. That's the normal policy, normal practice.
Yeah, a normal practice, yeah, we do it. Also, remember, there are some children who are actually born with HIV too.
Of course, that's what I'm referring to.
Yeah.
I just wanted to go back to the external patient program and the external radiation therapy. And Bisham, perhaps you may want to clarify. Now, the National Radiotherapy Center does provide radiation treatment. So the 327 patients listed in the submission, is it patients who are outsourced?
Correct.
Right. So what is the basis then for outsourcing these patients? How do you decide which patients can be treated at National Radiotherapy Center and who are outsourced?
The National Radiotherapy Center is currently being upgraded to include a new LINAC accelerator because the equipment that currently exists can only treat a certain spectrum of cancers. The only ones we send externally are ones that cannot be treated at NRC. So this 300 plus patients are patients who cannot be treated at NRC.
But, okay, so those who can be treated at NRC, what is the waiting time for treatment?
They are treated.
The next question.
There is no waiting time for treatment at NRC. If there's one area within the ministry, there is absolutely no waiting time. It is cancer treatment.
Okay, so when you say the patients, those who cannot be treated at NRC would be what category of patients? Can you give me an idea?
I can actually give you a list of the criteria that we use in order to send patients externally.
Right. Can you provide that?
That will be provided in writing, sure.
Right. In terms of the screening for cancer, because of course cancer, like the others, cardiac disease and renal problems, a big burden on healthcare. In terms of screening programs at CMO, can you maybe tell us a little bit about whether there are any formalized screening programs for cancers in Trinidad and Tobago?
So from a women's health perspective, we can provide those to you through in writing if that would be best from the Director of Women's Health. Most of the screening programs are conducted, the screening programs are primarily conducted through the RHAs, the Regional Health Authorities, because that's where the services are, the patients, the point of care happens, the opportunity to do opportunistic screening happens there. The RHAs, in terms of having, they would occasionally, on a schedule, they will have, you can get conducting pap smear clinics, for example. Pap smear drives, for example. But then I know that there are services, pap smear clinics, that actually are routinely scheduled within primary care health centers. So that is one example, a routine schedule of pap smear clinics within health centers. Then the outreach facilities with the mobile clinics where they will do the pap smears is another one. Breast examination is another one that is performed at the level of the primary care interaction with the primary care physician and the patient, or within the other interaction, other patient-physician consultations. In terms of whether these fit within a defined cancer prevention program or within a reduction program or a sort of very formal program, I cannot tell you that at this point in time. I'll have to get that information.
But can you undertake, because I know one of the remit of the Director of Women's Health, because I was involved in that at a different time, would have been to look at national cancer screening. So maybe you can provide, I know the director has been appointed for perhaps
yeah, and he has been very, very active in doing so, and there are lots of activities that
so maybe you can provide
yes, will do.
A report to the committee.
Yeah.
And also, if we can include in that any study that would have looked at the impact of the HPV vaccine on cervical cancer. I know that that vaccination, is it still provided free of cost to the population?
Yeah. So you're talking about locally conducted studies or studies?
No, I'm talking about the impact on the local population in terms of what impact it has had, whether we've had studies to speak to that.
Impact evaluation, with your permission, Madam Chair, impact evaluation is a particular type of approach to measuring effectiveness of programs. And I will see what we can assemble in terms of proxies for a formal impact evaluation, because a formal impact evaluation requires a particular process. Yeah. So we can see what we can assemble.
I would like to think that when the program was being implemented,
well, effectiveness,
some attention would have been paid to an assessment.
The outcome is what we can talk about. We can talk about the outcome, number of persons, the reduction in number of the change in cancers. We could talk about the number of persons who were vaccinated. In the true sense of impact evaluation, that requires a longer period of time to assess impact, but we can definitely give you outcomes and output in measures.
Yeah, that would be fine. And just to close, would you want to just remind the population in terms of cancers, what are the common ones that face us as citizens in Trinidad and Tobago?
So in terms of breast cancer is one of the significant cancers that impact on that affect the population. Lung cancer and its relation to cigarette smoking is another one of the risk factors, and cigarette smoking has been recognized as one of those, the key interventions, cessation of cigarette smoking, to prevent lung cancer and to reduce the burden. Prostate cancer is another one of significance for men. Colorectal cancer is another one that is of significance, and I think those would be the main ones that we see within.
Just one more question. In terms of children who may not be able to access or have been refused treatment by the Children's Life Fund, is there any avenue for those children to apply or to access any of these special health programs by the Ministry of Health? PS, CMO Director, EPP.
Mrs. Sitaram.
We have started discussions with the CLF to see how best the ministry can support the work of the CLF, as well as provide the best care for all patients. We have been having discussions for a couple of months now as to what we can do to supplement what the CLF does. So yes, there is an avenue that is opening up for children who are unavoidably denied at the CLF.
How soon can we expect some pronouncement on that?
Very soon.
Thank you.
There's just one question. I mean, there are several other questions we have here, but we would send them in writing. There's one question, and I don't know if the PS is the person to direct this to. A lot of our discussions really have been centered on the more technical, professional side of the special health programs. One thing I know affects the ordinary man in the street who accesses these programs is the loss of their files. Okay, they go in, the file is lost. How has that really been identified as an issue? Because I know you all treat with complaints and you measure success by complaints. And what, I call that customer care, I don't know if that's the real terminology. What mechanisms are we putting in place to treat with that?
Yeah. But, well, the answer refers to our earlier discussion where you were inquiring about the ICT system. Really, that is what is necessary. Because what is happening is that people are going from one hospital to another, and that's the other problem. And the same tests are being redone. So it's not just the loss of files, it's the expense that is being incurred by the country from having to duplicate the tests over and over again. So I will take your question as a suggestion, and I will ask our various divisions to engage with the RHAs to see whether there's a way in the interim that we can improve, at least on the process of the file management, because there's also the issue of simply files getting lost within the system within one hospital, right? So we do need to manage in multiple ways.
I just want to say this, PS. While we are charged here in this committee and looking at the money side, there is also a big heart side. And for a sick person, you know, battling all the things they're battling, you know, one has cancer and you're being treated and you go for treatment and they can't find your file, or they're reading somebody else's file, and you yourself might realize they're reading somebody else's file. You know, for us to sit here and talk just maybe about money might seem heartless. I would like to think that all of us here have hearts, and really hope that we don't have to wait till something that is heartless, ICT, to render some heart
what
on our part.
I'm hoping to do is within the next few months engage resources directly under the ministry to identify special projects, and this is quite likely a good example of one that may be simple to implement, but we need to identify what is causing the problem. Hopefully it will be simple to implement and get a resolution that could really benefit.
Thank you. I'm sure everybody's happy to hear that, and you know, Mr. Madri,
you will ask me the question.
I will ask you about it.
in 2 years' time.
Okay? No. Certainly soon after the budget. Okay? All right. So I want to say to the PS, to the program administrator, EPP, to the director HIV, the director Medical Research Foundation of Trinidad and Tobago, the director Health Policy, the chief medical officer, the health advisor, health promotion, and the State Council 3 acting. I want to tell you thank you for a very engaging discussion on a topic that really touches the hearts and comfort of our citizens. As I say, we have many questions still to ask, but we also have to have a heart in terms of the time. And therefore, I want to, at this stage, bring this part of our meeting to an end and suspend the meeting. I want to thank the members of the media who've stayed with us, and I want to thank the members of the listening and viewing public who've also stayed with us. I want to wish you all a safe journey home, and again, I thank you all. This meeting is now suspended.